Good evening. My name is Doug Hanto, and I am the co-chair of the Surgical Ethics Working Group in the Center for Bioethics at Harvard Medical School in Boston, along with my co-chair, Dr. Teresa Williamson, a neurosurgeon at Massachusetts General Hospital. On behalf of the Surgical Ethics Working Group, I would like to welcome everyone to our 2025 Harvard Surgical Ethics Conference. Our session this evening is Current Controversies in Transplant Ethics. We will host two more sessions on April 21st and April 28th. We would like to thank all of our participants from the United States, Canada, and around the world. We'd like to thank you for getting up early, staying up late, and taking time off from work or leisure to join us this evening. I believe we have an exciting 2 hours ahead of us. I would like to review a few housekeeping items before I introduce our topic for this evening and our moderator. We would ask that the attendees please submit questions at any time using the Q&A feature found in the Zoom meeting controls at the bottom of your screen. Selected questions will be discussed after all three of the presentations have been completed. Once again, please use the Q&A feature for all of your questions. If you have any technical issues, please use the chat feature to send a message to all the panelists, and a staff member will help. We would prefer that you not put questions in the chat this evening. We'd also ask that you continue the conversation online with hashtag HMS Bioethics in your social media posts. And also, if you're interested in other webinars, bioethics news, or HMS educational programs, please subscribe to the center's biweekly newsletter at bioethics.hms.harvard.edu/subscribe. Now, it's my pleasure to introduce this evening our moderator, Dr. Richard Whyte, who is the Vice Chair of Quality, Safety, and Clinical Affairs in the Department of Surgery at Beth Israel Deaconess Medical Center and Professor of Surgery at Harvard Medical School. Dr. Whyte earned his BS in chemistry, his MD from the University of Pittsburgh, and MBA from the Wharton School at the University of Pennsylvania. He is interested in bioethical issues pertaining to the field of surgery, particularly cardiothoracic surgery. Dr. Whyte is on the ethics committee of two national surgical organizations, the Society of Thoracic Surgeons, of which he is the chair, and the American College of Surgeons. He will be introducing this evening's speakers and moderating our panel discussion. Dr. Whyte?
So, Doug, thanks very much for the kind introduction. It's my pleasure tonight to moderate the session. I want to welcome all the participants into the second of our four-part Harvard Surgical Ethics Conference. Tonight's session, which goes from 7 o'clock to 9 o'clock, is entitled Controversies in Transplant Ethics. And we're going to have three talks discussing various aspects or controversial areas in the field of transplantation. The first is going to be normothermic regional perfusion and the dead donor rule. This will be by Dr. Keren Ladin, who I'll introduce in just a second. The next talk is ethical considerations in uterus transplantation by Dr. Louise King. And the third will be ethics of brain dead donors as experimental xenograft recipients by Dr. Doug Hanto, who just introduced me. So first, I'd like to introduce Dr. Keren Ladin, who's an associate professor in the Department of Community Health at Tufts University. She's director of research in aging ethics and community health at Tufts and leads the practice to policy translational research in the clinical and translational sciences postgraduate program at that institution. Dr. Ladin studied history and philosophy and social studies of science and medicine as an undergraduate at the University of Chicago. She earned her master's degree in population and international health from Harvard School of Public Health, and then a PhD in health policy, also from Harvard University. Dr. Ladin's scholarly work examines questions of equitable allocation of health resources, shared decision-making, and disparities, especially for older adults and for people facing surgical decisions. She's been funded by numerous public and private organizations and has served as the chair of the UNOSET's United Network of Organ Sharing Ethics Committee, as well as the Organ Procurement and Transplantation Network, or OPTN, Ethics Committee. So with that, I'd like to welcome Dr. Ladin to discuss her topic, normothermic regional perfusion and the dead donor rule. So Dr. Ladin, it's yours.
Thank you so much for that kind introduction, and thank you for the opportunity to share some of our work. All right, great. So I'm going to share some work that we did as part of the UNOS Ethics Committee, and in particular, a special work group that was formed with multidisciplinary expertise from various folks engaged in normothermic regional perfusion. And I'll talk specifically about the ethical controversies that we face with this new approach. So as you're all aware, there's conflicting ethical goals in transplantation. We have these utility goals to save as many lives as possible by ensuring that the greatest number and the best quality of organs are procured, while simultaneously we have a goal to allocate organs in a way that is fair and predictable and systematic. A third goal is really around respect for persons and promoting autonomy of patients. And then finally, we are stewards of the public trust, and that is really what what frames our transplant system, and is really the scaffolding of a system. Without public trust, we have no organ transplant system at all. So in the U.S., over the past several years, there's been a number of controversies and several kind of foundational reports shifting the way in which we allocate organs and shifting some of the legal and regulatory landscape of organ transplantation. We can talk about that, I'm sure, in the second half. But one of the drivers of this was a National Academies report that came out in 2022 that really underscored some of the issues and concerns that the community had around inefficiencies in organ procurement and issues surrounding fairness and equity related to organ allocation. And the costs of disagreement, public disagreements and controversies in transplant is quite real. So in other countries, in Germany, for example, we've seen that a decline in public trust corresponds subsequently to a decline in organ donation. And so the community, has, I think, good cause to be concerned when the public is either not informed or ill-informed, or there's controversies that are unresolved in the field of transplant. And NRP, or normothermic regional perfusion, presents one of those controversies. And you can see here some recent public media describing what the public is perceiving to be a controversial technique in organ procurement that attempts to reduce the transplant organ shortage. Okay. So just to kind of set the stage, DCD, donation after circulatory death, is growing in the US numerically and as a percentage of all organ donors. And I want to take a moment to kind of describe why we are focused on NRP in particular as an approach to organ transplantation. So NRP is unique, which is why we're considering the ethical implications. Unlike machine perfusion techniques, NRP involves the restoration and circulation regionally within the donor body before the organs are removed, and after circulatory death is declared on the basis of cessation of circulation. And it's important to note here that NRP differs from standard DCD approaches in which no blood circulation occurs after death is declared by circulatory criteria. So when restoration of circulation occurs with NRP, ligation of vessels and other methods are used to prevent circulation from reaching the brain. And this is a crucial difference between NRP and other forms of organ procurement. Just to clarify, there's two main forms of NRP. One is ANRP or abdominal NRP, and the other one is TANRP or thoracoabdominal NRP. And while both include restoration of circulation after death, TANRP or thoracoabdominal NRP is additionally unique in that it involves restoration and circulation through the heart. So they reanimate the heart and restart circulation to the organs. This is just a figure kind of showing the different times in which death is declared, differences between brain death and circulatory death, and I can come back to that if there are questions. And just to clarify why, why are people excited about this new technology, or not technology, this new approach? It's a controlled operation. All organs for transplant are perfused with a machine, and there's immediate functional assessment of the organs. There's a higher yield and better outcomes than with standard approaches. So, given that this is an approach with great promise in terms of higher quality organs and greater yield of organs, but also a lot of peril in terms of public trust, and certainly some of the unique aspects of this approach, UNOS put together a special work group to engage in a deliberative process. And so the ethics committee, which is the committee at UNOS that oversees some of these ethical questions, engaged stakeholders from diverse perspectives in a collaborative process to consider the implications of NRP. And to do so, we brought together members who had expertise in NRP, meaning they engage in NRP routinely, experts in the law, OPO members, donor family perspectives, procurement coordinators, abdominal and thoracic transplant surgeons, and ethicists. And so additional members that were engaged were the OPTN patient affairs committees, heart, liver, lung, OPO, transplant coordinator committees, and other work groups. And this work group met 15 times from July 2022 to March 2023, receiving presentations from relevant stakeholders and contributing to a literature library of over 60 relevant publications at the time. Presenters included European and American practitioners of NRP, organizations opposed to NRP, interventionists, and neurologists. And an informal work group of a survey of our work group conducted in October 2002 indicated that the deliberative process was working well. So many respondents had to some extent changed their minds about NRP following introduction of new evidence and deliberation. So, our attempt here was not to arrive at a conclusion a priori, but rather to really delve deeply and engage stakeholders to better understand and guide implications of this practice and to reach a thorough ethical analysis. So our ethical analysis was based on 3 principles that are commonly used in transplant ethics: non-maleficence, do no harm, respect for persons, or otherwise known as autonomy, and utility. And these are the principles published in the OPTN white paper, the ethical principles in the allocation of human organs. These are ethical principles that have guided much of transplant policy and much of at least the UNOS guidance that has been put out by the ethics committee. And so the ethics committee and this work group has attempted to balance these principles and to assess the degree to which they apply in the case of NRP. Okay, so implications for non-maleficence for NRP, it has 2 main implications for non-maleficence. Most importantly, there is a concern that NRP violates the dead donor rule. So the dead donor rule states that donors must be dead at the time of organ procurement and donation, and that donation itself must not cause death. And there's a number of different variants of this rule. We chose to adopt this definition of the dead donor rule deliberately because it is consistent with how the OPTN has referred to the dead donor rule, across all of their prior work. The concern with non-maleficence here stems from the circulation being restored after circulatory death has been declared. And this raises meaningful questions about whether the person continues to meet criteria required for the determination of death. And while there's no intention to resuscitate, we maintain that this alone is not sufficient to provide assurance that no harm has occurred. Also, NRP donors are not assessed for neurological criteria, so it can't be said that at the time in which donation and organ procurement occur, that brain death criteria is met. The second issue regarding non-maleficence is that more research is needed to confirm that perfusion of the brain or the brain stem during NRP does not occur. Specifically, more robust evidence is needed to rule out potential collateral blood flow through the spinal cord. And there's been some preliminary research that we can talk more about, but both in animal models and some Doppler studies, but kind of given the seriousness of this issue and the serious repercussions of violating the dead donor rule, the ethics committee and the NRP work group consider that further evidence, could provide assurance and allow the public trust to be maintained, which is critical. Implications of respect for persons. So we acknowledge that it's challenging to balance the need to adequately inform donor families with the difficulty of explaining some of the components of NRP, but because of its uniqueness, we feel that some of the components are very important to explain and understand. Specifically, we recommend that there be a conversation with donor families about the fact that while the donor is declared dead by circulatory death criteria, circulation will be restored regionally, and this may include the heart for TA-NRP at a time when the patient donor has not been assessed for the criteria for brain death. And we also suggest a conversation include the potential restoration of cerebral perfusion. And we heard over our deliberative process that there are conflicting and differing perspectives on the appropriate balance, both from donor families and OPOs and others. But this needs to reflect an informed decision-making process by which people understand, what it is that they are authorizing, and that there be kind of broader engagement with the community, including with different religious groups. In terms of uncontrolled scenarios, the committee discussed uncontrolled scenarios, and those are scenarios in which circulatory death occurs unexpectedly, not after withdrawal of life-saving treatment. Given that the transition from a living patient to an organ donor is rapid and potentially confusing in uncontrolled situations, this compressed time frame raises concerns about non-maleficence and respect for persons. And it would be difficult to achieve informed decision-making under these scenarios. So therefore, the committee determined that concerns regarding non-maleficence and respect for persons do not justify performing uncontrolled scenarios of NRP. And this conclusion was unanimously supported by all members of the work group and the committee. So implications for utility. An examination of the impact of utility finds that NRP has great potential for increasing the number and the quality of solid organs procured compared to traditional DCD. And specifically, there might be an increase in the average number of organs that are transplanted per donor and a decreased rate of allograft failure. Although this is very encouraging and we are all excited about this prospect, utility alone is necessary but insufficient for arriving at a conclusion about how NRP should be practiced and adopted. Just to, this is just kind of a summary slide, but just to say that, I think in some areas we really need more research. Specifically, we have to better understand the utility for public health. If the public distrusts this approach, we have some concerns about overall utility. And also, I think, one issue that we haven't talked much about is really potential harms, not only to the donor population, but also to transplant providers. Feelings among transplant clinicians are mixed. There's certainly have been accounts of moral distress among clinicians concerned about restarting the heart, and these should be examined more fully as this practice is adopted, widespread. So I think, we are at maybe past a point of reflective equilibrium, but we're thinking about kind of how, in what cases NRP should be used and how to pursue it in an unbiased way. I think for the interest of time, I won't go through kind of all of these questions, but just emphasize that, in a time where science and public health can be somewhat polarizing, I think we need to emphasize the importance of trust and trust in the organ transplant system and trust in OPOs and in the community. And one way to ensure trust is to have, deliberative, engaged stakeholder participation, meaningful engagement in decisions about policy, and kind of not allow these issues to kind of be taken up by the press and run with in that way. We should really be ahead of that. So just to conclude, I think that the work group agreed that NRP presents a promising and exciting technology that has the potential to increase the number of transplantable organs and to increase the quality of these organs. And undoubtedly, we all agree this is a worthy and important goal. And as with all new technologies, consideration of how the technology or the approach can be implemented ethically is critical to its widespread adoption and to its acceptance by the public. So the Ethics Committee and the NRP committees work groups shared the enthusiasm of the transplant community in developing and implementing solutions to improve the transplant system and reduce wait times and death for patients awaiting organ transplantation. And we also affirm the sacred trust and commitment of the transplant community to organ donors and donor families to maintain, the highest of ethical standards. And it's with these commitments and understandings that the committee concluded the following that require consideration and resolution, and that is that we need assurance that NRP adheres to the dead donor rule, that non-maleficence must not be violated in pursuit of NRP, even if positive utility outcomes could result. We need more standardized and transparent protocols, including adequate informed decision-making with patients pre-mortem and families approached after about donation. And we need to take care to kind of report the salient information to these families and decision makers. And finally, the committee agreed that uncontrolled scenarios of for any form of NRP should not be performed at this time because of the added concern regarding non-maleficence and respect for persons. And with that, just some references that are in public access online. And I'm happy to take questions in the second half.
So, Dr. Ladin, thank you very much for that presentation. To the folks in the audience, what we're going to do, and we didn't mention this before, we're going to do all three talks, and then we'll have an extended time for Q&A. And I would ask everybody to please put your questions in the Q&A box rather than the chat box, which we're trying to reserve for technical issues and communicating amongst each other here. Anyway, that was a great presentation regarding normothermic regional perfusion, and I suspect there'll be some questions about it in the final session, the Q&A session. But we're going to move on to the second talk, which is on uterine transplantation, and I'd like to introduce Dr. Louise King, who's an assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School and a surgeon within the Division of Minimally Invasive Gynecologic Surgery at the Brigham and Women's Hospital here in Boston. Dr. King is also an attorney, and she completed her Juris Doctorate at Tulane Law School before attending medical school at the University of Texas Southwestern Medical Center. She completed her residency in obstetrics and gynecology at Parkland, again at UT Southwestern, and a fellowship in minimally invasive surgery at Stanford University. Her interests in medical ethics focus on questions of informed decision making and assisted reproduction, as well as equitable access to advanced gynecologic surgery. So, Louise, the podium is yours. Thank you.
There we go. Uterine transplant. I'm so happy to be here. I was lucky enough to be able to invite my students from our health law and ethics class at Boston University Law School, and I was told to encourage all of you, if you're on the line, and I'm sure you are, to feel free to submit questions. So everyone's really excited that you're here. And thanks everyone for joining us for these talks. Certainly a change in pace from the previous talk. This is the area of transplant that affects us in reproduction at the moment. I have no disclosures for you. So currently the suggestions for indications for uterine transplant are for anybody with absolute uterine factor infertility. And if that concept is foreign to you, that can occur in two instances. One is fairly rare. It's a congenital condition, the MRKH syndrome. Nobody ever uses the full name. But essentially somebody who's born without a uterus in place, but has XX chromosomes. An additional way to achieve this would be, or to result in AUFI would be that you acquire it. You have had, for example, cervical cancer and had your uterus and cervix removed, but your ovaries are retained prior to completing a family. You have very severe fibroids affecting the uterus, or trauma, for example, and you've lost your uterus for those reasons. So anybody who does not have a uterus in place so as to gestate a pregnancy would be eligible. And that's a fairly large population of people who could be eligible for this. Up to 1 in 500 persons worldwide per year. Of note, most groups that have looked at the ethics of this and the feasibility of this have so far excluded the possibility of trans persons or men having a transplanted uterus. It's certainly feasible. I think we would need to do a lot more study to be sure that we could use the neovaginas that we create from, for example, a variety of different tissue to make them hospitable for the uterus to be implanted into that space, and then, of course, to menstruate, as we'll discuss, because that's required ahead of an implantation. But it is definitely feasible. It'd be a little bit more difficult for a man who didn't wish to have his anatomy changed so as to create a neovagina and thereafter gestate a pregnancy. That would be much, much more difficult, because you do have to, once you've transplanted the uterus, have it menstruate at some point. So the big key is, where do you menstruate from? The alternatives to uterine transplant in the setting of uterine factor infertility would be gestational surrogacy. In many countries, that is now illegal. For a long while, it was possible in some countries, but there were a number of abuses. It was not that the practice itself could not be done ethically, but that the people that were employing the practice in those countries were not achieving it in an ethical fashion. Here in the United States, it is legal. It is practiced in many states, and we have many excellent success stories. It does require very careful legal involvement so as to ensure a parity between the people paying, because you do essentially pay, you subsidize the care of somebody and the life of the daily activities of life of somebody who is a gestational surrogate. So there is a substantial cost associated with it, and that exchange of financial support and then the nature of the relationship that is then created requires careful legal protections in place to ensure that there is no abuse. So it is possible, but for a lot of people, it's seen to be something that would be a very difficult thing to do to scale, and to do in an ethical way to scale, in part because of the requirements to keep equity and parity within the relationship. There's also, of course, adoption, but that doesn't involve carrying a pregnancy, actually gestating a pregnancy, nor will that child be genetically related to you. And then in the next 10 to 20 years or so, we will surely see advances in the artificial wombs that have been developed and tested so far primarily on sheep, but with very good results. So there will be, I would guess, not in my career, but potentially in some of the people on the call, artificial womb in the future that we could potentially use. The uterine transplant itself followed a timeline as described in this PowerPoint slide. The person pictured is Matt Brunstrom, who was the most successful of those pioneering this technique. His support came from a private foundation of a family directly affected by the MRKH syndrome, who were interested in seeing this proceed forward. So a very substantial donation was put into place, and they pursued primarily live donors because there had been significant complications and failures in the context of cadaveric uterine transplant. There's been significantly more than 60 now, where the picture I've shown you is from articles describing all of this in 2019. But by today, we're up to 100 successful uterine transplants, and success is defined by the graft, so a successful graft, but there have been about 50 babies born now. In terms of feasibility and cost, the initial process forward to create this technology and this method of transplantation followed what you would expect, a very careful, rigorous process of study in animal models and then transitioning into the human. First, as I described in the slide prior, or as was seen in the slide prior in Turkey and with cadaveric, without as much success as the then significant successes of the Swedish group with private funding. So live premenopausal donors have had the most success. There are also some postmenopausal donors. Notably, those donors first have to go through a trial with estrogen stimulation to make sure that the uterus is viable and can menstruate, and that carries some very significant risks of clot and stroke. So again, the most success has been seen in most programs around the world with live premenopausal donors. This is one of the few, if only, areas of transplant where you have somebody donating who is alive, but is not donating a truly life-sustaining organ. And I'll talk about that a little bit. The cost in the United States is up to $200,000. That includes the cost of IVF. What is not included in $200,000 is what's quoted in the literature, but what's not included in that estimate is the long-term follow-up, and I will also address that in a few slides. So $200K is just to get to one live birth. Previously, many of the initial uterine transplants were done through open laparotomy incisions. Many of the groups have transitioned to robotics, significantly decreasing the morbidity of the different procedures. But as you can see by the depiction on your screen, the procedure, as you can imagine, to harvest a uterus with associated vasculature is much more complicated than a standard hysterectomy. You're going to be recruiting a very normal uterus. So the donor, the live premenopausal donor, is not going to undergo the same hysterectomy that I would perform for them if they wish to have a hysterectomy for pain or uncontrolled menorrhagia, for example. That hysterectomy with a normal uterus and no significant surgical history or adhesions or endometriosis or the like would take me maybe 30-40 minutes. The surgery to recruit the uterus with the associated necessary vasculature for grafting is much longer, on the order of many hours. So there is a significant risk and morbidity associated with it for the donor, separate and apart from like a traditional hysterectomy if they had an indication for that for cause. As I mentioned a moment ago, there have been a number of study designs and studies. The donor workup as people are proceeding forward to donate includes all of this testing that you see there, including some estrogen priming, especially for a postmenopausal donor, which again carries some pretty significant risks. We want a pap smear and we want an endometrial biopsy. We want to be sure that there is no cancer in the uterus itself. There haven't been, certainly they're going to do imaging studies, CT angiography, and probably also an ultrasound, although it's not listed on most protocols, to make sure that there's no anomalies of the uterus. We don't want to perpetuate that. They're not screening for endometriosis, and I don't know what would happen if you transferred, for example, an adenomyotic uterus, which is impossible to diagnose ahead of time, into a person without that disease, which is quite painful and has a lot of negative impacts, including negative impacts to fertility. So there are a number of holes in the donor workup so far that have been created. The recipient has to go through 6 months to 1 year menstruation, as I mentioned earlier, to demonstrate the graft success. and then they'll go forward with implantation of an embryo. The delivery must be by cesarean section, and then thereafter, unless they plan a second pregnancy, that's not been done yet in any of these cases. So there's never been more than one, but that's a minimum of 3 surgeries. There's also, of course, to be considered, as in any transplant, the side effects of immunosuppression, nephrotoxicity, bone marrow toxicity, diabetes, etc. You can read them. And it's important to note that comorbidities and complications during gestation are more frequent in organ transplanted persons or women. So we know that from people who become pregnant after kidney transplant, for example. The follow-up post-hysterectomy should be up to 10 years and ideally for a lifetime, but this follow-up is not included in the estimated costs, and so far long-term follow-up has not been achieved in any of the cohorts that have delivered. The neonate or child is going to take on the following risks: low birth weight, preterm birth, preeclampsia, which can affect low birth weight and preterm birth, potential for rejection episodes that could affect the gestation and the health of the gestation. There will be higher rates of spontaneous abortion and intrauterine death. To my knowledge, I think at least 1 or 2 have been reported so far of intrauterine deaths. Similarly, neonates and children should have long-term follow-up, but to the best of my knowledge, those have not been defined in the study protocols nor included in the costs. There's an exceptional article written recently by a group out of Korea exploring all of the ethical issues that are raised by a uterine transplant. Certainly, it's an excellent option for persons who have uterine factor infertility insofar as it achieves their goal of not only having a child that is genetically related to them, but also carrying the child forward in a gestation. But there are significant risks associated with this, and it's very difficult. I apologize, I scrolled through too fast. It's very difficult to quantify those risks in the context of the benefit that's achieved. How do we actually assess that? Similarly, who should uterine transplant be available to? I mean, if one of the main goals that's articulated by most groups that are going forward with this is to ensure that people have the option of carrying and experiencing gestation, all the more reason to make that available to persons like trans women or even men. That should be on the radar, and yet it's been completely excluded by most analyses by most of the groups who are going forward in their ethical analysis within their groups. There's very little discussed about the health conditions that might disqualify a person from being a donor or a recipient. I mentioned one example, adenomyosis, in terms of the donor. In terms of the recipient, it's very rare for us to tell somebody, with the exception of some cardiopulmonary diseases or significant musculoskeletal diseases, that they could not perhaps attempt pregnancy. But this is far beyond attempting pregnancy. And we really should define like what are the risks and benefits, and where should the limits be in terms of comorbidities that would prevent us going forward with this. And then in terms of rationing of a fairly scarce resource, although many, many more people coming forward to donate in this context, who would have a greater priority over whom? One of the questions that I find incredibly interesting and would like to explore with you is the public funding of this as an option. It is publicly funded in Germany right now, and there are many attempts right now to get this publicly funded through insurance, and I'll address that really quickly in just a moment. And then finally, would a woman's decision to undergo uterine transplant generally be autonomous? How do we truly assess autonomy in this context? And I raise that in particular because there are certain cultures where the ability to carry and gestate a pregnancy is exceptionally important. When I've been on ethics committees looking at potentially starting programs in uterine transplant in hospitals here in our local areas, a lot of the discussion is about who would we be most likely to see seeking this out. And there are many instances where people would be seeking it out because without the ability to gestate a pregnancy, their ability to maintain their particular role within a family unit or within their culture and society might be compromised to the point that they might be ostracized. And to what degree do we want to participate in that? Granted, it can be incredibly detrimental for the person who is unable. I take care of a lot of people who come to me for surgery to try to optimize their uteri for gestation. And what they explain to me is if I'm unsuccessful, if our surgery is unsuccessful, their entire life will take a very different trajectory, and one that is a very negative trajectory. And I very much want to help them. But is this the right path forward to help them? I'm not 100% sure, despite my heart breaking for the situations that they find themselves in and are subjected to, honestly. And then existing allocation principles, as I've mentioned, don't really neatly transition themselves to uterine transplant. It's such a unique form of transplant. So I've covered many of these. We're treating a form of infertility, but there are other options that exist. Should this really be covered under insurance in the United States? It raises justice concerns for me. I'll cover that in one more slide in a moment because of the costs of IVF and the lack of access to IVF and ART generally in this country. When Max Brandstrom was so successful with his first transplants, he gave talks at most of the major conferences in the United States for people who do the work that I do for reproductive surgery work. And in each of, I saw his talk 3 times in succession at each of the major conferences that year. And in each one, he said that he felt that his work in this space was the key factor that made it so important was he was helping these women, as they explained to him, to feel like real women again. And I don't doubt that that's true, but it truly raised a question for me about how we looked at women who were seeking this out, how we look at women generally in our society, how we value their ability to gestate or how we devalue their lack of ability to gestate. And it really, for a lot of people, not just me, felt very uncomfortable. And it's one of the reasons that there have not been more programs that have been started in this space, because we're not sure exactly what we're supporting when we push this forward. And then as I'll finish with justice concerns in the United States. So the biggest question right now, everybody skipped over my concerns so far of, how are we going to really fund long-term follow-up? And what is it that we're actually treating here? Is the ability to gestate a pregnancy truly something that we should prioritize? And I've alluded to the fact that we don't really have an idea of how we would allocate uteruses themselves, but perhaps we should be looking at this more in a broader context of how do we allocate assisted reproduction? Perhaps that's the bigger space in which we should be thinking about scarce dollars, scarce ability to help those who are affected, and ensuring that we perhaps approach it from a utilitarian perspective and truly help the most people, as opposed to focusing on something so narrow as uterine transplant, which is exceptionally expensive. This is a slide to explain to you that a very large proportion of Americans cannot access assisted reproduction. They might have a perfectly functional uterus. Perhaps their fallopian tubes are not functional. Perhaps they're part of the 50% of infertile couples where the issue is sperm count or sperm quality. But they can't access assisted reproduction because it's either not covered or it's too expensive. If instead we took our $200,000 per live birth and translated that into ensuring that people could have access to assisted reproduction, we could help at least 10 or 20 couples to achieve their goal of fertility. And so I think that once we're to the point, and I don't even think we're there yet, although many people are pushing to get there right now, but once we're truly considering whether this should be something covered by insurance, I feel like we need to hold the line of not pursuing that unless and until we can be sure that we have global access to assisted reproduction first and foremost, which is already expensive, but less expensive than uterine transplant. So to sum up, there are some significant justice issues, some significant issues around follow-up and really assessing the true complication rates long-term in this space. I would hold until we know more about that. But if I'm overruled on that point, at the very least, we should ensure equity before we move forward with ensuring this is available to people from an insurance standpoint. So thank you so much. I'm really looking forward to your questions about all of what I've raised.
So Louise, thank you very much for that. It certainly raises some provocative questions, and I'm looking forward to the question and answer session afterwards. We're getting a few submissions to the Q&A session, and I would again encourage people to put their questions or comments in the Q&A rather than in the chat box. Anyway, our third speaker is Dr. Doug Hanto, who's co-chair of our surgical ethics working group here at Harvard. And he is the Lewis Thomas Professor of Surgery Emeritus at Harvard Medical School. Dr. Hanto received his bachelor's degrees from St. Olaf College and an MD from the University of Arizona and a PhD from the University of Minnesota. He completed general surgery training and transplant surgery training at the University of Minnesota. He was chief of the Division of Transplantation and clinical director of the Transplant Institute at the BI Deaconess Medical Center from 2001 to 2012. He received his master's in bioethics from Harvard Medical School in 2021, and his current areas of interest include disparities in healthcare and organ transplantation, ethics of organ transplantation, medical assistance in dying, and using fiction to discuss ethical principles, issues, and controversies. Dr. Hanto is going to talk to us about the ethics of brain-dead donors as experimental xenograft recipients. So, Doug, feel free to start.
Tonight, we will examine the ethics of using brain-dead donors as experimental xenograft recipients. I have no financial or other conflicts of interest to report. The possibility of solving the organ shortage with genetically altered pig organs has given more hope to transplant than any other recent advance. Yet there are a number of ethical issues that arise in xenotransplantation that are listed here. We will be focusing on the last issue, the ethical concerns regarding the use of brain-dead individuals for xenotransplant research, which has been done at New York University and the University of Alabama, where brain-dead individuals who are not able to donate are used as experimental subjects with family consent. Pig kidneys have been transplanted into these nephrectomized individuals, and the kidneys monitored for rejection and the recipient monitored for adverse effects, including infections. One of the advantages of this approach is the ability to examine the interactions between the recipient and the transplanted organ without subjecting a living human to the attendant risk. This will be the topic that we'll examine in more depth tonight. In 2016, the National Academies of Sciences, Engineering, and Medicine convened an expert multidisciplinary panel to dig into questions of how the organ donor intervention research could be facilitated. What methods could be applied to improve the availability and quality of organs for transplantation? What interventions were most likely to be effective? What were the ethical, legal, and regulatory barriers? There are several conclusions and recommendations, but the panel emphasized that research in deceased donors was justified as long as there was respect for the deceased donor and their families, and that studies designed and performed would not adversely affect trust in the donation process. They also argued that recipients of these organs should be treated as research participants. But the question remains that if the decedent is not a suitable organ donor, can they be used as a research subject? Early on, it was recognized that institutional review boards, or IRBs, could not perform the review and oversight of research involving brain-dead and recently deceased subjects because federal policy requires that IRB reviews are limited to living human subjects. The first Committee for Oversight of Research Involving the Dead, or CORID, was formed at the University of Pittsburgh to provide oversight of research involving brain-dead subjects, non-heart-beating deceased subjects, and recently deceased body parts and tissues. This 2004 paper outlines their initial experience. In February 2004, an interdisciplinary consensus panel was sponsored by the Winship Cancer Institute and the Center for Bioethics at Emory University. This consensus panel on research with the recently dead, CPRRD, recognized the need to balance the potential benefits from this research with moral obligations for the recently dead. They developed ethical guidelines for research with the recently dead that was published in 2005. Consensus panel publication defined the primary ethical concerns with the summary statement noted here. As a precious natural symbol of humanity, cadavers, changed here to the recently dead, should be treated in a manner that is consistent with respect for the value and dignity of the once living person. Such respect requires that research with the dead abide by the deceased person's life goals and treats his or her body in a dignified manner. In other words, respect for persons is the guiding principle for such research. To this, we can also add Kant's requirement that we should treat persons as an end and never as a means. More recently, New York University established the NYU Medical Ethics Working Group on research in the recently deceased that has investigated the ethical, legal, and social considerations in performing organ transplant research in brain-dead subjects. It should be pointed out that the NYU Ethics Group and the Transplant Surgery Group have been thought leaders in the ethics of xenografting into the recently deceased and the ethical and scientific value of the use of the decedent model. As part of their planning process for research in the decedent model, NYU subsequently established a Research on Decedents Oversight Committee, or RDoC, within the Office of Science and Research. This multidisciplinary committee is comprised of scientists and non-scientists, including physicians, nurses, and certified IRB professionals, and reviews all research proposals involving deceased donors and reviews all research proposals involving the recently dead. Let's examine some updated guidelines that incorporate the work from the 2004 CORD Committee, the 2005 Consensus Panel, and the updated work by Parent and Montgomery at NYU. Let me briefly summarize the major guidelines that have received consensus agreement. Then we will discuss each of these in more depth. First, the research must address an important clinical problem. Second, scientific review of the research proposal is required by a properly constituted expert review board that must approve the research. Third, community involvement and transparency is required, as is coordination with the local organ procurement organization, or OPO. Donor eligibility must be clearly defined in advance, and the dignity of all research subjects must be preserved. Finally, time limits should be imposed on the research and should be part of the informed consent. Let's now look at the first guideline in some detail, that the research must address an important clinical problem. Everyone in the transplant community and the general population is aware of the long-standing unmet need for kidney transplantation resulting from the organ shortage. There are over 100,000 people currently waiting for a kidney transplant, and only 1/3 will ever receive a transplant. The remaining 2/3 will become too sick to transplant, or they will die waiting. Other patients similarly wait and die waiting for heart, lung, and liver transplants. Pig organs hold great promise for solving this shortage. One can make a compelling case for the scientific rationale for the experiment, but we can only scratch the surface of this rationale today. First, the risk-benefit ratio. The potential risks, such as zoonotic infections, are thought to be low, and the potential benefits to patients with organ failure are high. Furthermore, preclinical data in non-human primates shows 100% heart survival rates over 8 months. However, the first 2 living recipients of pig hearts both died within 2 months, raising the question as to how predictive the data from the non-human primate model, pig to non-human primate transplants, will be in humans. It has recently been written that the complexity of the immune system cannot be replicated in a dish, or in this case, in a non-human primate, suggesting that at some point, taking preclinical animal model data into the human model is always necessary. And it's worth mentioning that just this week, or the end of last week, one of the two remaining surviving pig kidneys was recently removed because of rejection at about 4 months. So it's not dissimilar to our experience in the pig kidney. Further justification for studies in the decedent model for both heart and kidney is the fact that studies in NHP have been ongoing for 30 years. And although discoveries have been made, there is still no phase 1 trial approved or in the pipeline. A major benefit of using the decedent model is to be able to examine directly the human biologic response to a pig xenograft and make future changes based on the data. In addition, these data can be obtained by the frequent sampling of blood, xenograft, and lymphoid tissue in the decedent without requiring living humans to take the risk of undergoing a complex experimental procedure. This is a huge advantage. The next requirement for experiments in the decedent model is that a detailed scientific review of the research proposal in a decedent must be performed. This must be performed by a properly constituted review board that must approve the research. As mentioned earlier, because federal regulations define human subjects as living human beings, the requirement that research involving human subjects be reviewed by an institutional review board, or IRB, does not apply to research in the decedent. Therefore, a multidisciplinary expert panel should be established to evaluate the scientific validity and the value of the research, as well as any applicable preclinical data. Part of the review of the research proposal is to guarantee proper informed consent. Informed consent is ideally obtained from the subject before death, but will usually be given by the next of kin or other authorized parties, since most potential donors would not have considered this type of intervention before death. The decision to donate should demonstrate respect for the decedent and be consistent with what the decedent would have wanted for themselves. The decision to donate should also consider the concerns and needs of the family. Disagreement among the family members should be considered as an exclusionary criteria. Additional requirements of the informed consent include the following. The next of kin or authorized parties are freely able to withdraw the decedent from the study at any time. Other ethically sound reasons for the suspension or termination of the study by the investigators should be provided. The ability to withdraw without penalty should be included in the informed consent. The investigators and the institution should have mechanisms and supporting technology to maintain the confidentiality of the decedent and their family, including the preservation of de-identified data and permanently stored specimens for possible future study. The next of kin or authorized party that signs the informed consent should be informed they will receive no compensation. It should also be disclosed that the next of kin or authorized party that signs the informed consent will not have to pay for any of the research expenses. At the end of the study, the transplanted kidney will likely be removed in the operating room and the decedent will be embalmed or cremated to reduce the infectious risk. This should be included in the informed consent form. It should also be arranged and stated that the decedent will be taken to a place previously determined by the family for burial or internment. Whether research results will be offered or disclosed, and if so, when, should be communicated to the next of kin or authorized parties. There are ethical concerns about the use of pigs for human xenografting. These include the fact that these animals are genetically modified and cloned and must be bred and housed using infection-controlled measures like artificial insemination, embryo transfer, cesarean births, and isolation in sterile environments without contact with other animals, preventing the expression of their natural behaviors. Their use would require frequent blood and tissue sampling, which in pigs may require restraint, including drug-induced restraint. Investigators should be sure that the organs are coming from a facility compliant with all of the applicable animal care and welfare protection regulations and is appropriately certified and inspected by the appropriate regulatory agencies. There's some important additional guidelines for research in the decedent model. Community involvement and transparency are important in the review, approval, and oversight of research in brain-dead individuals. Proactively involving members of the community will help to build trust between the research and public communities. There should also be close coordination with the local organ procurement organization. The local OPO should determine whether the decedent is a candidate for organ or tissue donation. Ethically speaking, organ donation should always take preference over research. Investigators should not be involved with the declaration of brain death or decisions regarding the withdrawal of care. Once brain death is declared and the decedent is ruled out for organ and tissue donation, the OPO will determine whether the decedent was committed to organ donation. If so, the OPO will mention to the family the research project. The OPO is best positioned to initially approach donor families. If they're interested, the investigator can then join the conversation to explain the research in detail. The selection of the research population should be part of the research proposal. Eligibility must be clearly defined. In other words, the investigators must justify the selection of the research population, in this case, brain-dead individuals. This justification in the case of the recently deceased includes the risks and benefits of studying the decedent compared to living subjects. The scientific advantages should be outlined, how harm to other subject populations, including animals, will be prevented should be discussed, and finally, the feasibility of the study should be provided. Processes must be in place to preserve the dignity of all subjects. Living individuals have preferences about the disposition of their body after death, and honoring the decedent's preferences shows respect for the person who is alive and may prevent emotional distress in the living. Honoring preferences shows the living that their preferences after they die will be followed. And respect for the decedent demonstrates respect for the family and friends who have an emotional connection between the body and their loved one. A time limit should be set on the duration of the experiment so the family knows what to expect and that is not an open-ended experiment. It should be as short as possible due to family considerations. In conclusion, using brain-dead individuals as experimental xenograft recipients is ethically acceptable if certain guidelines are adhered to. These include scientific review of the research proposal. A properly constituted review board must approve the research. Community involvement and transparency in the review, approval, and oversight is required. Close coordination with the organ procurement organization is critical. Donor eligibility must be clearly defined, and the dignity of all research subjects must be preserved. And finally, there should be time limits imposed on the research. We'll provide these references in the slides that will be sent out subsequently to all the attendees. And I'd like to thank you for your attention, and I'll be happy to answer questions during the panel discussion. Thank you very much.
Well, Doug, thanks very much for that presentation. Again, raises some interesting issues. I had a couple of questions, but I think we should get everybody, the panel, get their pictures up. So we got about 16 questions in the Q&A, and we'll go through them, but I don't know whether we're going to get them all done. I've been kind of reading them as we've been going through here, but I'm going to start off with the first one, and fairly quickly, I think that I would point out that the person that asked the first question missed Dr. Ladin's email address. I don't know whether you can put it in the, if you're comfortable putting it in the Q&A there or not, but the question was, and I don't know, maybe Dr. Hanto may be the best one to address this. I don't know, maybe Dr. Ladin. Does the medical field have a firm belief on the definition of patient death? And it's sort of a classical question in the field of transplantation. Is death defined as brain death or cardiac death, or do you need both? Keren, do you want to take that, or Doug, would you like to take that, or Louise?
Well,
It's
I
up to
can,
you.
I can start. We do have a good concept of the definition of death. I wouldn't say everyone agrees on it, but I would say that there's a general consensus. So I think that we have established that there are two mechanisms of declaring someone dead, and that is first brain death by neurological criteria, and secondly by absence of circulation or circulatory death criteria. And both of those are legally accepted ways of declaring death. Of course, Dr. Bob and I think Keren has already mentioned the dead donor rule, and we can come back to that. And generally, we adhere to the dead donor rule, and that means that the removal of the organs or organ procurement cannot cause the death of the person. And the person needs to be declared either brain dead or dead by circulatory criteria in order for organs to be legally removed. So I think that those are well accepted criteria. I think, I don't know how much we want to get into Bob Trug's questioning the dead donor rule. And I think that there has been a lot of discussion of this, and maybe it'll come up later in the discussion, but maybe we can leave that for now. But just to answer the question, yes, there are those two mechanisms of declaring death.
So next, Keren, do you mind if I share your email address on the
Oh,
chat?
yeah,
So
sure. I
people
can
get it?
put it,
Okay.
I can put it in the chat.
So the next question, and we'll just go through these as things go along here. And I think, Keren, this is probably best addressed by you, as you were on the committee that it references. How did the UNOS committee reconcile the need for patients who undergo normothermic regional perfusion to be regarded as dead for the sake of the dead donor rule, while also acknowledging that patients undergo NRP might have some sensory experience? Are we worried a patient undergoing NRP might have sensory experience? And doesn't that definitely rule them out as dead?
Okay, well, yeah, I guess the softball pitches are done for the night. So, I guess I want to say that there's a diversity of views on the work group and on the committees. We certainly heard from Jim Burnett and others from the American Academy of Neurology about the most recent research around kind of understanding the implications of potential collateral flow. I think that I don't think that anyone had concerns over pain sensations, but I think that people were of diverse opinions about whether the person was truly insensate and whether we could say that definitively, and what scientific evidence we would need to bring to bear. Having said that, to Doug's point earlier, Dr. Hanto's point, we have established ways of determining death, but there's a lot that's unknown also that may be true in this case. I think the dead donor rule specifically responds to these kind of socially constructed definitions of death that we have. And so in that, potential violations of the dead donor rule and the implications of that, we are concerned about this, mostly the social costs around that, and I think our social contract with the public. But in terms of, I think that more evidence about exactly how much collateral blood flow and what can be said about that is important and would make people feel ultimately more comfortable that non-maleficence is not being violated. But I will say that that was not like the only concern or even kind of the most primary concern.
Well, I know that was a bit of a difficult question, but I mean, the concern is there any sensation? So the person's heart has stopped. They are put on some circulatory assistance, but at least with the thoracic one, the head vessels are all clamped. So there should be no flow in the carotids. There should be no flow in the vertebrals. Is the point that there could be some blood getting there through some yet unknown mechanism?
I don't think it's a yet unknown mechanism. I think that people, so both testimonials from people who are involved, but also I think demonstration that there's potential collateral blood flow through the spine is what people are worried about. So you're right that there's not a lot of blood flow to the brain because of the tying off of vessels and all of that. But to say that there's no collateral once you restart the heart, I think there are a few people who said that. Most people said that the collateral blood flow was not likely to make someone sensate. But I think that not likely is a challenge for us when we are in this liminal space and have to decide, and have to say that the person is definitively dead and insensate.
So Ken Kern asks, is the general public aware that restarting a heartbeat does not mean a chance for resumption of life? Regardless of brain death, they might think that perfusion might in some off chance restore life. And how do you reassure them? This is getting to your question of the public confidence in this methodology.
Yeah. I mean, I think my colleagues here too have to describe really complex situations, and many of us ethicists do. That's our kind of our professional charge, is to describe complexities in ways that are accessible. I think that there are few in the public who engaged with us through the public comment period who believed that somebody was like going to be resuscitated and live. Like, that was not a misconception. I think that different people and different faiths have different beliefs around death and restarting the heart, even if it doesn't mean that you are, you're going to get up and walk, right, or have some sort of meaningful life. To your question, I think that we did do a good job. And I think the transplant community has a hard, it's a very challenging task to explain these very complex situations to people, and especially during times of great need and, great emotional strain. But I think people actually do a very good job describing what is the difference between life and death. I think NRP complicates it because to some degree, the person has been declared dead on the basis of cessation of circulation, and then circulation is restored. And that is confusing to folks, to some folks.
Karen, could I just kind of as a follow-up to that, just ask, so the donor wishes, have been made clear, they've made it clear that they want to be a donor. That desire to honor the donor's wishes, does that influence at all a tolerance for risk? Does that factor into the risk-benefit equation, or is it a little bit more black and white than that?
So I think one of the one of the important arguments in favor of NRP is that it allows people for whom being an organ donor or families for whom this is very important to be organ donors in situations where they might not otherwise be able to, just owing to kind of the timeline of their death. And that is important. So, that's part of respect for persons, and that's part of kind of this social contract that we have with the public. Having said that, no, I don't know how to interpret your question in terms of an appetite for risk. So, we don't allow people in the US currently, as far as I know, there's not a great appetite for overturning the dead donor rule overall. There are some, calls for reconsidering it in certain circumstances, but I haven't heard that that's like a mainstream consensus yet. So I don't think that, however strong someone's inclination to donate organs, I think that there are pretty bright lines with what OPOs do and don't do. Although I see that we have, a real expert among us. I don't know if Alex Glazer wants to chime in about, her perspective here. Yeah, but I think there are some bright lines, Doug.
So I want to get on to the uterine transplant question. I mean, we took these questions as things were going, but there was one that got out of order here. I just want to continue on this line of questioning, one more question. And it is, if NRP protocols are constructed to adhere to the DDR, the dead donor rule, then why are we going for such a detailed disclosure to the donors and families? Current practice does not provide donors and families details about other surgical recovery or organ perfusion techniques. So why would this be any different? And I've abbreviated the question a little bit, but it's true. I mean, having been involved in donor procurements for in prior positions, you don't go and describe the gory details to the family. They give consent for organ donation, not to, we're going to give them a high potassium cardioplegia, and we're going to do this, and we're going to do that, and we're going to clamp this. And then we're going to, they don't get that degree of detail. Why is this NRP different?
So I think it's the same, for the same reasons that we started, at the very beginning of the presentation, to say, in what ways is NRP unique from other, established and well-accepted forms of organ procurement? And I think that one of the main differences is that there is disagreement about whether it abides by the dead donor rule. So I don't think that there is widespread consensus, at least in this report and many others. People are concerned about whether it does. And so, I think that there are these meaningful differences, and part of, I think, being, a steward of organ and of organ transplantation more broadly is understanding what are the salient points to the public in terms of signing on to organ donation. For many people, knowing that the heart is going to be restarted and that blood is going to flow through the organs within the body is meaningfully different from what we do in all other forms of organ procurement. And for that reason, I think it should be disclosed so people can make an informed decision. I don't think that means that we need to disclose every, detail of the process, but that meaningful distinction should, I think, be part of this informed decision-making that families and individuals should have a chance to make.
Doug or Louise, what do you think of that?
I'll defer to Doug. This is not my area at all. I have thoughts on it, but it's not my area, so I don't want to speak out of turn.
I think I agree with Keren. I don't share as many of the concerns about NRP as perhaps the committee did, or some of the committee. But I do think that there is enough concern that I think it's always better to be more transparent than less transparent when things are, not necessarily agreed upon by everyone. So I think there are certain advantages of doing that. I do worry a little bit sometimes, though, that depending on who's doing the disclosure, we know this about informed consent. We oftentimes tend to infuse our own beliefs in the process of explaining. And I think one has to be very careful to be objective. And I think, like Keren said, you don't have to go into all the details, but I think you do have to express some of the concern. But on the other hand, I think one of the concerns of the concern is that you're getting into territory that's pretty murky for the experts, let alone for the families. So I think that there is, some risk there that you open up Pandora's box and you introduce some uncertainty just because of the knowledge difference, and that could, be detrimental to the informed consent process and potentially lead to the loss of a donor, not necessarily for reasons that someone felt strongly about it, but because they just really didn't quite understand, or their misunderstanding led to maybe unnecessary concern. So, but I think on balance, it's a good thing to disclose. As Keren's pointed out, it's different than anything else we do.
It is. I kind of worry that you might scare people off. I mean,
Mhm.
I think when you get consent for an operation, you have to be comfortable with the degree of detail that you give the patients. A lot of it is based on trust. I think that we have sometimes the residents talk to patients about informed consent, and they go into excruciating detail about the risks of the operation and less on the benefits. And I worry a bit about this, that you might scare people off if you go into too much detail, but just my own biases. There was a question for Louise. An anonymous attendee says, do you think that there will be concerns of distributive justice with uterine transplantation across the US when this option is utilized more? For example, states that are more restrictive on women's health. This is right up your alley.
It is right up my alley, although I've been loving the conversation about the dead donor rule and the concerns and balances there. It's been fascinating. Yeah, and I'll combine that with a question that was earlier on uterine transplant, which was, what happens if somebody has a rejection of their organ mid-pregnancy? And, then what do we do? And I think the two questions are interrelated. That within the United States, access to meaningful reproductive care that does include meaningful access to abortion care is not uniform. I think that's probably true about a lot of aspects of care, in the sense that, another commentator in the Q&A commented on how this type of transplant requires very complex vascular grafting, and so can only be done in very specific centers. So it'll always be kind of limited to very specific centers. And certainly in all the aspects of advanced care that we provide as clinicians, there are limitations to which center is proficient enough in providing that advanced level of care. But putting that aside, there's a unique nature to reproductive health care in this country currently, because it is not the same state to state, and in some states exceptionally restrictive. To use the example proposed of somebody who has a graft rejection, that's one of the reasons why they have a 6-month to 1 year time frame, where we have to make sure that the uterus is menstruating and truly accepted, and there's no rejection, because you don't want to find yourself in that situation. But at least for teams, for example, here in the Boston area, or somebody commented on other issues in other countries and in any international area where they've handled pregnancies in persons with transplanted organs. They're ready for and looking for way ahead of time any indications of graft rejection. And you would proceed forward to maximize the outcomes as defined by the person who is pregnant. So if, they experienced in the first trimester an apparent complication related to the graft and wish to terminate, the ideal process would be to go forward with termination at that point to maximize their health. If instead a complication ensued later in the pregnancy, that's where these justice issues would really come up, because terminations, at least in Texas, for example, still currently aren't available after 6 weeks, but certainly wouldn't be available if you're into the 3rd trimester, even in the setting of a graft rejection. So I think that calls into question a lot of the programs that currently exist. The biggest program, as somebody pointed out again in the chat, really exceptional attendees tonight who are really on top of all this, is in Texas. And so currently, if you go forward with a uterine transplant and then a pregnancy with a transplanted organ and you start experiencing rejection, I'm totally unsure of what people would be able to do or offer you, because the current standard in the state of Texas is that you have to have a life-threatening issue at that moment, or at least a well-defined one. Whether that would rise to the level of a life-threatening issue is probably would pretty quickly. But again, it's this problem in those states, especially in Texas, where defining that moment where things get so bad that you could intervene under a criminal statute is very different from defining what's in the best interest of the patient and having an actual shared deliberative informed consent process with them. And so being hampered by that statute, I think, really compromises the ability of us to proceed forward in this space in those states.
Well, I'm glad you brought up that issue of what happens with rejection in pregnancy and rejection, because that was one of the other questions that came up in the Q&As is what's the effect of uterine transplantation when they're successfully impregnated and then undergoes transplant rejection? Isn't the early fetus and later in the pregnancy viable? So, well, isn't the fetus also at risk? And that person has no autonomy. And how do you resolve that issue with a potential 200% mortality along the lines of the living-related liver transplants?
And so, so I don't really think of it as somebody who provides abortion care, although it's not the primary aspect of my practice, but taking my cues from people who really focus on this care, especially, for example, maternal fetal medicine specialists. It's not that, if somebody is presenting in extremis and is pregnant, let's say at 20 weeks, as you mentioned, it's either 200% mortality or you proceed forward with the termination and you save the life of the pregnant person. If they are a little bit further along, you might initiate a delivery so as to ensure that, and then see if you can resuscitate. But I don't know that it's really a question of a fetus's autonomy. Autonomy is defined as your ability to self-govern. So infants don't have autonomy either, but we act in their best interests to the best of our abilities. And so if somebody is in that state, we would intervene to achieve the best outcome in consultation with the person who's pregnant. Frequently, for example, in more common scenarios where people present with severe complications later in their pregnancies where they're closer to term, frequently patients will decline interventions and try to sort of play the game with the clock and see how far they can get along to closer and closer to their due date, and will take on some pretty extreme risks. Because at that point, clearly in the context of somebody who's gone through a uterine transplantation to achieve a pregnancy, you're dealing with someone who strongly desires that pregnancy. So you're going to be actually probably working with them to try to be sure they understand the risks that they're desperate to take on to get to the end of that pregnancy. And so in the context, for example, again, of the graft rejection, it'd be highly unlikely, right, on a rate of 10 to 20% based on other types of uterine transplant after a 6-month to a year timeframe. So it's unlikely, but if it does occur, you would probably be dealing with somebody who's willing to take on some pretty extreme risks to try to act in the best interest of the child that they strongly desire.
Louise, thank you. I want to change direction a little bit. And Mary Klingensmith writes, "This is an international audience, yet most of the speakers' remarks and studies quoted are from the USA and North America. Can the speakers comment on whether ethical frameworks around transplantation should vary or be influenced by local or national or norms, or are they universal regardless of the country? Doug, do you want to take a stab at that?
Well, I think that in today's transplant world, um, uh, most of the practices and procedures in transplant are pretty similar. I mean, there are some differences in organ procurement and who is a donor. So there are countries that have opt-out programs. So in the United States, we have what we call an opt-in program. That means you have to sign a donor card and say that you are opting in to be a donor. In other countries, such as Spain, you are assumed that you want to donate your organs at the time of death, unless you have registered that you don't want to be a donor. And that has been one of the explanations for their high rate of organ donation. So there are some subtle differences like that make a difference. Um, uh, I think that, as Keren has pointed out, I think that the dead donor rule is pretty well adhered to around the world. And I think although there's been some debate about it in the United States, it's still adhered to here and around the world. I do think that there is actually been voiced many times a lot of concern that if we were to change the dead donor rule here, that it could have wide-ranging influence around the world. And there are some countries that are not regulated as well as we are, and it could be potential problems. But I might let Keren, respond as well to that. But I think that in the modern world of transplantation, it tends to be an international specialty.
Yeah, I would agree with that. I mean, I will say, like, we only had 20 minutes, which is like hardly enough to talk about the US context and limiting to the global context. But I will say, in the context of NRP and our work group, we had many presentations from our wonderful colleagues in Europe, in the UK, Spain, Belgium, many other countries that came to talk about their process for deliberating and determining how to move ahead with NRP and kind of what the protocol should be. And that there's a lot of things that vary between our countries, both in terms of how organ procurement overall proceeds, especially between the US and UK, but also, as Doug was pointing out, differences in context of designating being an organ donor, and opt-in and opt-out systems have, tremendous implications for pre-mortem interventions, and how donation proceeds. So, I think in particular around uncontrolled contexts, in which I think colleagues in the committee and work group here in the U.S. had strong feelings, and those differ, for example, with our colleagues in Spain. So I do think that, I think that there are some universals, certainly, but context matters, and we see that even within the U.S. in terms of how people move ahead, but definitely in the global context.
So, Doug, going along the lines of the brain dead donors, Oscar Velovich asks a two-part question. And he says, given the brain dead donors are still biologically functioning with support, where do we draw the ethical line between organ donation and using them as platforms for experimental research, especially when the outcomes may not benefit the donor or their family directly? And how might using brain dead donors for xenograft research impact public perceptions of organ donation and trust in the transplant system? Do you see any potential for backlash?
I don't see a lot. I think that, I think, there are people who say, are we going to have I mean, they think of the book by Robin Cook, Coma. I don't think that we're in that kind of a neighborhood. I think that it's very clear that, as we pointed out, that transparency is very important. Having scientific review of the proposal by a properly, expert panel is really important. There needs to be institutional support, and I again think that transparency is extremely important. Um, so, I think that the use of brain dead donors is not going to be huge, but I think it can be really, really beneficial. I know that there was a great deal learned from the recipient at NYU that was kept, that the kidney was monitored for 60 days. That's in the process of being reviewed for publication as we speak. And I think that I think it does really. I think one of the biggest advantages, as we've seen, is that the experimental models between pig and non-human primates is just not as predictive as we would like of what the outcome is when you do that same transplant into a human being. Even though we're very similar genetically, we're not identical. And obviously, and so those differences seem to make a big difference in the outcome. So I think it's important, and I think it may take on more importance if we see more of these kidneys being lost in the human recipients.
Louise, one of our participants or audience asks, says, thank you very much for the excellent talks. Regarding uterus transplants, what follow-up has been done on babies born from a transplanted uterus? And how are these babies' rights and best interests protected before birth?
In answer to the first part of the question, I mentioned that there hasn't been enough follow-up. There isn't any specified in the protocols or the research papers that have been published. Of course, many of those papers came from Europe, from Turkey, from Sweden primarily. So they're coming from a lot of different countries where these programs originated. They didn't originate in the United States. Ideally, we would have very significant long-term follow-up. As a comparator, we're only now starting to better understand the effects of IVF long-term for children who are now adults from IVF. And there are some things that we're finding that are unique to IVF children that pose some risks. So I think very long-term follow-up is really essential here. In terms of protection of rights and best interests of children before birth, I'm hard pressed to define that completely. It implies that implies something that is not currently the law, except in Alabama, which is that a developing fetus would have specific rights enumerated. In terms of the best interests, we defer to the gestating parent. And again, try to typically, again, if you're working with a person who has gone to the lengths to get a uterine transplant, they absolutely want to arrive at a live birth, and they are absolutely deeply concerned with the best interests of their gestating fetus and eventual child. So it's not usually a conflict. It's something where everybody is aligned to try to achieve the best outcome for the person who is pregnant and for the fetus, and then eventual after birth, the child. In terms of whether people should go forward with uterine transplant, when there are other options available that are less risky in terms of the preterm birth risk, preeclampsia risk, other risks that I enumerated that come along with people who are on immunosuppressants in general, and then specific to uterine transplant with potentially less robust blood supply, for example. That's a question of risks and benefits in terms of whether we should be pursuing this as as an option that would be, for example, more widespread and covered under insurance. Again, in that scenario, I would say we don't know enough yet. We need more study. I think it's worth studying. I would never say not to study it, but I don't think that it should be mainstream and offered under insurance as it is in Germany.
We have a comment and a question here by Jonathan Marin, who is the director of the Harvard Center for Bioethics. And Jonathan says a common theme across these talks is ongoing efforts to increase the supply side of the disconnect between the supply and demand when it comes to organ transplantation. But each of these different efforts comes with a significant ethical challenge. What kind of efforts are being made to work on the demand side, i.e. to decrease the need for transplants? And are such efforts any less ethically complex? Doug, I'm going to direct that one to you. I mean, this involves all kinds of transplants, right? Liver transplants, kidney transplants, pancreas transplants, uterine transplants, lung transplants, heart transplants, you name it. I think there's a lot of work being done to decrease the demand side. But the focus of many transplant centers, the focus on this talk is to look at the supply side. But Doug, have you got any comments to Jonathan?
Yeah, I think there are a couple of really good examples. One during my career, my lifetime in transplant, has been the development of effective drug therapy for hepatitis C. So hepatitis C, if we could get our act together, could really be eliminated from the world because of the medications that are available for treating it. So we could, and we have really substantially reduced the incidence of liver failure from hepatitis C. It used to be the #1, and it's no longer. And not only that, but in terms of utilization, used to be that patients that were transplanted for hepatitis C inevitably got recurrent hepatitis C, and a significant proportion of those went on to lose their graft within sometimes 6 months to a year. So the introduction of those drugs has made a huge difference in terms of reducing the incidence of hepatitis C related cirrhosis and liver failure, which, by the way, also reduces the incidence of hepatocellular carcinoma, because hepatitis C is one of the primary instigators of hepatocellular carcinoma in the liver. So I think that's one really good example. Another good example is the disease that's now overtaken hepatitis C, and that's non-alcoholic fatty liver disease. And there's a tremendous amount of work being done, and has been for many years, in anti-fibrotic medications to reduce the fibrosis in the liver from any number of liver diseases, whether it be that or sclerosing cholangitis or biliary cirrhosis. So yes, there is certainly a lot of work being done, and I could give more examples, but yes. And so I think it's a good point. But of course, for kidney disease, we still have a huge population of patients that develop type 1 and type 2 diabetes that go on to develop kidney failure. Some of these are related to lifestyle issues, and some of them are genetically determined. But I think we can continue to work on some of the lifestyle issues and do a better job of that. But
I think to add on to that, in my own area, I haven't done it for a while, lung transplants, we typically, that's really the only option you have for many of these end-stage lung diseases, end-stage COPD, pulmonary fibrosis, so on and so forth. Cystic fibrosis, obviously potential genetic therapies for that. But so many of the end-stage lung diseases don't have effective therapies, and that's the role for transplant. But I don't know whether anybody else has wants to chime in on that, but we are running a bit short of time. And Doug, you asked me to wrap it up around 8:50 or so, because you have a few housekeeping issues. So Keren or Louise, have you got things to add to that last point? And I apologize to the people putting questions and we didn't have time to do them, but there are a lot of questions and there are very good ones.
Excellent questions. We're doing a lot in women's health. So one of the ways that you have absolute uterine insufficiency would be cervical cancer. I mean, think of the amazing advances we've done with a vaccine for HPV. We're essentially eliminating cervical cancer, though there are still some non-HPV forms of cervical cancer, but they're exceptionally rare. Advancing surgical techniques to deal with fibroids, to decrease them, and to follow them. My research team is currently exploring creating a proposal for early screening for women, especially for women of color, for fibroids when they're much younger, even in the teenage years, so that we can catch them as early as possible and make sure that people are aware of them and tracking them, and we can ensure that we intervene in a meaningful way so that they don't compromise for fertility or lead to a hysterectomy. I could come up with a, sexually transmitted, I could go on and on. There's tons of things that we're doing in women's health, but to Dr. Marin's point, they are equally ethically frustrating in the sense that we don't have enough funding. We're having funding pulled. We have justice issues and access to care for all of these factors. You're more likely to not have access to the vaccine for HPV and to have HPV and to have cervical cancer if you have less access to funding, less access to healthcare, or no healthcare coverage in many states. So yes, absolutely just as ethically fraught, but I would love to see more money and time spent there to prevent the diseases that lead to the need.
Karen, any final comments?
No, I mean, I strongly agree with those sentiments. I think, this is as important time as ever to monitor, track, prevent, and, continue to work on improving equitable access. I think, one of the silver linings perhaps that we have in transplant is that we have such a strong ability to monitor, because we do have at least, for people who make it to the wait list, we have a good sense of who gets an organ and how they do and who doesn't, right? So, I think it's a unique opportunity for us to continue to improve and continue to um, identify ways in which we can improve equity and improve monitoring. I think one of the things we haven't talked about is kind of how new technologies might help us do that better. Like, how can we use AI? How can we use other systems to kind of help us identify patients and track them towards these therapies in ways that are more comprehensive and streamlined. Yeah, I think these are really important issues and really excellent questions. I think you had your hands full with moderating today. Really an active audience. Thank you.
Karen, thanks very much. Doug, have you said you had some final wrap-up questions or wrap-up comments?
Yeah. Well, I'd just like to thank our presenters tonight, Dr. Ladin, Dr. King, and our moderator, Dr. Whyte, for their outstanding presentations and discussions of several critical areas of controversy in the field of transplantation. And these are ones that continue to evolve rapidly with advances in organ retrieval, uterine transplantation, and xenografting. I'd also like to thank all of you who listened tonight and asked questions of our panel. I'd also like to thank Dr. Rebecca Brandell, the Director of the Center for Bioethics, Dr. Wes Boyd, the Director of Education in the Center for Bioethics, and Dr. Jonathan Marin, the Clinical Director of the Center for Bioethics, for their unfailing support of this conference. Finally, I'd like to thank Jay Cowan, Victoria Cunningham, Courtney Lombard, Leslie Nicolini, Melissa Nozel, and Noah Venuti for their organizational, marketing, technical, graphic, and regulatory support of the conference. On behalf of the Surgical Ethics Working Group, we thank you for attending. We hope that you've enjoyed and learned from tonight's presentations, and we hope that there's information that you will be able to use as you address bioethical issues in the future. We look forward to seeing you at our next session on Monday, April 21st, when our topic will be ethical challenges in global surgery. Thank you again, and good night.